thank you for joining us. Thank you for joining us today for Confronting the Overdose Crisis, Black Men's Stories and Strengths in St. Louis. We have a lot to cover, so I am just going to jump right in. First, I want to make sure to introduce myself and our presenters. My name is Maria Paschke. I'll be facilitating the webinar today. So I'm the Director of Impact and Innovation with the Addiction Science team at UMSL-MIMH. I had the privilege of spending 3 years as full-time project staff on the center initiative supporting this work. Dr. Devin Banks is a licensed clinical psychologist and assistant professor in the Department of Psychiatry at Washington University in St. Louis and led the research project we're going to be sharing with you today. Kay Campbell is a doctoral student in UMSL's clinical psychology PhD program, and she was our lead qualitative interviewer for the project. Sandra Mann is the current director of the St. Louis Black Harm Reduction Coalition and the former program director for Power for STL, the T, which was a core partner of the Center Initiative. And finally, Keith Lofton is a certified community health worker, a certified peer specialist, and outreach worker at Williams and Associates. He was on the Center Community Advisory Board and is the current manager for the Black Harm Reduction Coalition CAB. So while we are the ones here speaking to you today, the Center Black Voices Project and the overall Center project was made possible through a deep commitment to addressing the overdose crisis in Black communities in St. Louis of many, many, many dedicated partners and individuals and organizations. The work was funded by the Missouri Foundation for Health, and core partners include UMSL Family Care Health Centers and Power for STL, but many other trusted community sites that provide harm reduction, outreach, service navigation, recovery services, and have worked tirelessly to help reduce these disparities over the past few years to promising results. You will be hearing quotes today and stories from the 35 men who participated in this project. This research takes place within a broader history of racial segregation and disinvestment. So we acknowledge research itself has at times contributed to harm and inequities. We're grateful to the Black men who trusted us with their stories, and sharing this out today is part of doing due diligence to their courage and honesty and insights. So I want to end my introduction before we jump into the speakers with a quote from one of the men that we spoke to. When I was growing up, this was the type of place where you can be lost and don't know where you're going, and you hear, "You all right? Matter of fact, you come spend the night at my house until you get up in the morning. You can get up at sunrise and I'll feed you breakfast." But now you can't do that because look what's going on. Our kids, they be dying. They die from gun violence. They die from pills. They die from all type of crap out here. And it's like, when is it going to stop? And I just wanted to pause on that because that's hopefully why we're all here today. We're here because we believe in a world that the speaker is describing, a community where people look out for one another, where no one is left without options or isolated. We recognize that the challenges facing our communities didn't happen in isolation, but they also won't be solved in isolation either. So addressing this crisis and creating that world takes all of us and takes all of us working together across organizations and systems and communities to build something better. So with that, I'm going to transition to Kay to give you some context.
All right, thank you so much, Maria. So I want to jump right on into the context, right, which is Black overdose disparities. So between 2015 and 2021, opioid overdose deaths surged in the St. Louis, Missouri region, but they surged 8 times more for Black residents than our white residents, right? And that was for a number of reasons. Not only did this include this historical and ongoing racial segregation and disinvestment and poor access to healthcare and resources that we saw more in our North City, St. Louis, but this also included, right, fentanyl being added to the drug supply as well as the COVID-19 pandemic. So here's another quote from a participant. It says, "Absolutely, the stigma, absolutely. Let's just be honest. They've got more access to that kind of help than Black people do. I went to a predominantly white high school. I know people that was white kids that were being sent to therapists and these fancy rehabs out of state, and they didn't want to get clean. That's the thing about this. You have to want it. And with us, it's almost like you have to want it twice as much because it's always going to be more difficult to access. So by 2021, Missouri had the fourth highest rate of overdose deaths among Black people of all U.S. states and territories. Even more so, Black men in St. Louis City was 2 times more likely to die from drug overdose deaths than any other gender or racial demographic group. So, what was our response? I will say, right, the Center Initiative. So, we had a research approach specifically that we utilized. So, the Center Initiative's mission was to reduce overdose, confront the impact of trauma, and really invest in the long term well being of Black people that were most impacted. And this included changing the narrative around drug use and recovery, promoting safe use and harm reduction, and increasing access to both traditional and non traditional treatment options. In partnership, right, with our core partners, which included the UMSL Addiction Science Team, the T, as well as our Family Care Health Centers. So we have one key question. Why was overdose increasing so sharply in Black communities? So together we used two projects, Center Black Advocates and Center Black Voices, to really explore the deep roots of the overdose crisis in St. Louis for Black communities. So our Center Black Advocates really engaged our community partners that work directly with Black people in St. Louis City. And our Center Black Voices involve interviews directly with Black men who use drugs to really uplift the voices of those most impacted. So, how did we carry out Center Black Voices? So, first, we recruited participants through three distinct settings, right? So, this included things like a drop in center as well as respite and recovery housing. And this approach really allowed us to reach Black men with diverse experiences of drug use. Men had to have used opioids or stimulants in the past month, but most men interviewed were actively using. We then introduced semi-structured interviews, right? So these were conducted by trained researchers with lived experience or cultural competency. And these interviews explore participants' life experiences as well as a number of other things. And in addition to having trained research staff, we also included our community advisory board members to serve as interviewers as well. And then we audio recorded and transcribed this into written format so that way the research team and community advisory board could work together to examine this data using a collaborative analysis process. So we used right one key approach, which I've mentioned. We had the involvement of a community advisory board, not just at one stage, not just at the ending, but at various stages, at every stage of the research process to really execute these projects. So here is one quote from Burton Barr, who served as a community advisory board member, and I will just pause and let you guys read that for a second. All right. And now we'll hand it on over to one of our amazing community advisory board members, Keith Lofton.
Hello and good afternoon. My name is Keith Lofton. Um, I work for Williams and Associates as a CHWC certified peer and outreach worker. I was also a part of the community, the CAB as we call it, the Community Advisory Board. So the question is, why was the CAB important, right? And the research was important. Well, first and foremost, it helps by them doing their research and me being a part of the CAB. It helped in the disparities because it provides research insight into our communities and historical context, and also helps build relationships with Black men that uses drugs. And why is that important? I'll tell you why it's important. Because it was very important for someone to be a part of the CAB, but also a part of research, because for far too long, Black men in particular were never a part of any research. 9 times out of 10, when it was research involved, it was normally by white researchers who didn't really have a feel for the community. So it was able to actually tell our voices. It was actually able to really dive deep into what was really the problem in our communities. And I was grateful to be a part of that because it allowed the board to actually have an input on what was being done, what was being said, certain areas that was actually being interviewed. We had also a hand-on, as you want to say, approach in choosing the locations, the spots, like LIV, for instance, and in submitting the question. So what they would do was they'll come back to us, Keith, Andreas, Gerald, what do you think about these questions, right? And we'll give our input, even all the way down to the posters, right? And what that did, that made us feel a part of, right? Because for far too long, we know what the narrative about Black men has always been, especially in the eyes of America. So, man, I was more than happy and more than proud to be a part of the Community Advisory Board, right? Not just as a member of the CAB, but I built relationships with the people that's within the CAB, which stretched far and beyond after the actual CAB was over. They helped me find my voice. It helped me also connect to actually go on to be a part of harm reduction. I mean, man, I went on various trips. My very first time on a plane to Puerto Rico, I was 48 years old, and it was with the cab from UMSL. I enjoyed myself. And since then, I have been on various trips uh, as far as being a part of UMSL and Community Advisory Board, to where they empowered me to start my own organization, starting our lives over. And they have been a part of that as well. So once again, man, thank you guys, and thank you allowing me for being a part of this.
Thank you, Keith. Thank you for being a part of it and for sharing your experience. My name's Devin Banks. Like Maria said at the top of the webinar, I am a psychologist and assistant professor of psychiatry at WashU. And I want to tell you a little bit more about who these men were that we ended up interviewing with Keith and the Community Advisory Board's help. So for the sake of confidentiality and privacy, I have to say that these profiles that I'm going to share with you are not actually representative of any one man we interviewed. Instead, they are more like amalgamations based on common stories that we heard. If you've seen our full report, there are 4 profiles in the report. But today I'm going to share with you just 2 of those. And the purpose of this is to give you a bit of a sense of the actual people involved in this project before I tell you about the themes that we heard across those 35 people. So meet Ray and Anthony. So Ray is in his late 20s and had only used marijuana until he was incarcerated. While in prison, he was exposed to heroin, fentanyl, and K2, which is synthetic marijuana, substances that often are easier to access in prison than basic necessities. Fentanyl use became a way for him to manage the psychological and physical trauma of incarceration. After his release, Ray was determined to seek help and begin recovery, but unfortunately, the sudden death of his mother derailed those plans. With a combination of grief, unstable housing, and unresolved PTSD from his time in prison, Ray returned to fentanyl use, now accessing it from the street to numb emotional pain and avoid withdrawal. He has repeatedly cycled through drug court since then, where he felt misunderstood and faced discrimination from social workers and court staff. Today, Ray is in peer-led recovery housing, where he is learning from and being inspired by other Black men who have found a way out of the cycle of addiction. Support from others with lived experience is helping him to explore new ways to cope in a safe and stigma-free environment. Second profile we have is Anthony. Anthony is in his 50s and grew up in a home where his mother sold heroin, providing him a front row experience to the drug trade from childhood. Although he grew up seeing his mother use drugs, she did provide Anthony educational and enriching childhood opportunities. But growing up around the drug trade, drugs were freely available when he became older and more curious about them. Unfortunately, Anthony now finds himself in the same cycle he witnessed as a child, making his current use all the more painful because he knew all along exactly what he was walking into. Because of this, he experiences deep shame, leading him to hide his drug use from his family and his friends. His physical dependence on the drugs leaves him feeling stripped of dignity and out of control. The shame he holds deepens the more he isolates and hides his use, resulting in him becoming more and more afraid to seek treatment. As a result, Anthony's main social contacts are with people who sell him drugs, and he has learned not to trust or rely on anyone except for himself. So again, like I said, those were amalgamations based on common stories we heard from some of the men that we interviewed. But hopefully it gives you a sense of the diversity of experiences that the men that we talk to have before we get into our key results or key themes here. So based on the analysis plan that Kay summarized for us a little bit earlier, we found 6 common themes across the 35 interviews that we conducted. I just want to shout out the analysis team really quickly because I think there were something like 10 people involved in getting deep in these transcripts between community advisory board members, like Keith and staff at UMSL-MIMH, and we really tried to do these stories justice by making sure that these themes reflected what the men actually shared with us. So 4 of those themes concerned inequities that drive overdose risk, and 2 of those themes concerned harm reduction and wellness strategies that men are using even in the context of those inequities to try to stay safe. So I'll go through each of them now. So the first theme, shamed and shut out, is about stigma and isolation. Men in this study often described harmful relationships that made it hard for them to stop using drugs because they were isolated from family and friends through rejection or through actual rejection or feelings of shame, much like we heard with Anthony. Because because of the sense that others looked down on Black people who use drugs and blamed them for their own addiction, men also felt that the community in general disregarded them. And they actually connected this directly to overdose, as you can see in the quote here. So this gentleman said, "Nobody wants to help a dope fiend. Nobody wants to help with a drunk. Great example, I was passed out drunk in front of my hotel room with a key in my pocket on the coldest night of the year. I lost my finger as one of them. What made me upset was how many people just walked past me and left me sitting there in the cold. Not even shook me and woke me up. Call the cops, there's a guy passed out here. People are desensitized to it. They don't care." The next theme around what drives overdose among Black men, we called living in the danger zone. This was really about how in Black social networks and neighborhoods, fentanyl is often omnipresent, meaning everywhere, and overdose is normalized. So men did talk about how a historical and current lack of investment in Black neighborhoods in St. Louis created environments where the drug trade and violence are common. They noted how the situation got even worse when fentanyl entered the drug supply, making that drug supply unpredictable. And they noted how the introduction of fentanyl into the supply did predominantly affect Black neighborhoods. The men noted that they often access drugs through friends or family members and did have close access to the drug trade from an early age due to the conditions of disinvestment in their neighborhoods. And that this easy access to powerful drugs when they got into adolescence or early adulthood and they started experimenting or were curious, they felt like they couldn't get out of the cycle of addiction because that access to powerful drugs caused painful withdrawal symptoms that led to continued use and many overdoses in the community. And for many of those men, overdoses were normalized, but they did not shy away from the fact that it was traumatizing to see how normal and common overdoses were. So one gentleman said, basically, another one bite the dust. It happens so much in Black neighborhoods. Sometimes they overdose and come back, and some people don't. You hear about it so much, you hear about people getting killed, overdose. It's part of the norm, but it is really not the norm. You get immune to it. Police sirens, helicopters, and gunshots. The third theme that we're calling trauma that never lets go was really about how undue or disproportionate criminal legal contact and neighborhood deprivation drive the addiction cycle, limiting stability and mobility for families across the life course. So Black men who use drugs in this study described facing a lot of practical problems that contributed to their inability to engage effectively in recovery or other more what they would consider more productive behaviors. This is like high contact with law enforcement, having issues with family and friends, potentially who also struggled with addiction, financial problems, and health problems. They talked about how consistently growing up in conditions where they faced those disparities often led to trauma and made their families less stable, which increased the risk of drug use and addiction. The lack of financial and employment and educational opportunities in their neighborhoods also made it hard to get ahead and stay healthy. So this quote is specifically about criminal legal contact. This gentleman said, even with the Good Samaritan law, which for those of you who don't know, is the law that in theory allows you to call the police if someone's overdosing and not be prosecuted related to calling the police for that overdose. Even with the Good Samaritan law, it don't work. This is Missouri. We still slave in here. They don't care. I'd have been beat down when the police left me there because I wouldn't say nothing. They left me on the curb. It's like, call your own ambulance. The fourth and final theme with regard to inequities was we'll call Left Without a Lifeline. It was really about substance use treatment. And men talked about how program barriers, interpersonal discrimination, and a lack of culturally appropriate care exclude Black men from treatment. These men talked about how they often don't get the help they need because of problems in the current treatment system. They have trouble accessing treatment because of barriers like cost, not having insurance, or the place not taking the type of insurance they have, especially Medicaid. and trying to balance other priorities at home when because a lot of the options are residential treatment and they weren't sure, they couldn't go away and balance other priorities at home. They also talked about long wait lists and confusing rules that make it difficult to get consistent help. Even when they did get treatment, they often had bad experiences that made them not want to continue or return, related to racial discrimination, as well as to some interpersonal issues. They felt that the care was poor, the rules were sometimes too strict, and often they encountered staff who seemed to care about more money than really about helping them, or who didn't understand them because they lacked lived experience themselves. So this person said, treatment just called me maybe a week ago, but I got a dog. And I was like, well, I can't just abandon my dog. I got a little place. And if I go in there, ain't nobody going to pay my taxes. Ain't nobody going to stay in my spot. And then the place might be broken. So you got to make a conscious decision what you're really ready to sacrifice to come up, or you got to stay down until you come up. So these last two themes, like I said, are about ways that men try to maintain wellness in this environment that I just talked about. This one we called Staying Safe in a Risky World, and was about the safe use practices and grassroots mutual aid that have evolved in particular in response to the unpredictable drug supply driven by the proliferation of fentanyl. So despite overdose disparities, Black men who use drugs have developed specific ways to stay safe, like using less, testing their drugs with fentanyl test strips, or other methods, trying to stick to regular drug sellers that they trust, and carrying naloxone, the overdose reversal drug. They don't use those practices just for themselves, but also to help others as well, because they are often the first to respond to an overdose in their community, especially given some of the past themes about disinvestment and long ambulance wait times. Some feel proud of helping keep their community safer. However, there also was some worry about getting in trouble with the law, or even causing others withdrawal symptoms when using naloxone to help someone, because they know how horrible that withdrawal can feel. So one person said, I was on the street since last October, so I've been having Narcan or naloxone on me. Especially during the winter time, I would walk around and check on people, especially the ones that are laying on the ground, the ones that I know that's on drugs. Check, make sure they're responsive. If they're not, make sure I call 911 immediately. And I always try to have some food or water on me, because sometimes we get hungry and we get desperate and stuff like that. What I've done to make my drug use safer is just being a human being to my fellow human being. And then finally, finding strength in community. This one was about Black men taking support from where they can get it, whether it was family that continued to rock with them, or whether it was the streets. But most importantly, they valued lived experience and community supports. So it was really important for Black men to have support from family, friends, and the community to stay healthy, and they noted that. Some depended on other people who use drugs for support, especially those who lacked family help, and they looked for and found comfort in the shared experience in those networks. Positive support from community organizations like churches has been helpful for many men, but they desired more support and acknowledgement of people who use drugs and the overdose crisis from community-based organizations. In particular, they felt there should be more activities and opportunities available in Black neighborhoods to help both support recovery as well as to prevent drug use among young people, to stop the cycle of addiction before it starts. They talked about sports, arts, neighborhood projects, mentorship programs, both, of course, for young people and for people looking to recover from substance use disorder. And then finally, they talked about the value of sponsors, of peers, of people with lived experience with drug use, and also with lived experience in the communities that they were from, as a way that they really found hope and strength, whether they were in recovery or just trying to maintain. So one person said, most of these people want to see somebody like themselves teaching. They're talking about in the context of recovery-based programs. It's kind of hard to listen and get that from another person that ain't never been on drugs, don't stay in the type of neighborhood you stay in, ain't been through any of those things. The only thing they could say is that they looked through a book, seen it on TV, maybe seen a few people that was on drugs, talked to 2 or 3 of them, and they feel like they can help. Most people's not going to gravitate to that. So this was just a snapshot of our results. We have way more quotes and way more information about what we found in this article that is published and open access, available to anyone online. So feel free to check out the QR code, and thank you for listening.
So now that we've given an overview of our results, we've built into this webinar some kind of brief times for some panel discussion with the speakers, just to switch up the format a bit. So we are going to have a few minutes here for some questions for Kay and Devin, digging into what they just shared. So my first question is for Devin. So there was a lot of information here already. If people listening take one thing away from our results, doing this research, what should it be?
Yeah, I think the one thing you take away might depend on who you are and what you do. So if you are, if you're a treatment provider or you have leadership in a treatment organization, maybe you're thinking about, how can I make my services more culturally congruent so people aren't leaving treatment and facing discrimination when it was so hard, when Black people are facing discrimination when it was so hard for them to get to treatment in the first place. Maybe if you are someone who is working in a harm reduction organization, you're thinking about how you can empower people who use drugs who you work with every day as first responders, knowing that they are often the first responders to an overdose, especially in Black neighborhoods where, like I said, those ambulance times can be long. But I think one thing we can all take away from this is that Black men who use drugs are people with dignity and humanity and agency, and they are highly stigmatized by all of us and by our society and by our local communities. And when we perpetuate that stigma in little ways or in big ways, we make it really difficult for them to do the things that we think they should do, including seek recovery, engage more adaptively or productively in their communities. And ultimately, I think these results show that stigma contributes to illness and death. And we all, no matter what our role is, we can all work on changing the stigma and treating Black men who use drugs, people who use drugs in general, with more dignity and humanity.
Powerfully put. Thank you, Devin. Sort of piggybacking off of that, Kay, what misconceptions about Black men and drug use do you hope that these results of this study dispels?
Absolutely. Yeah. So first, I hope, right, that it dispels that Black men are using at higher rates, right? I really hope that this also dispels the idea that overdose prevention for Black men can succeed without addressing this structural deprivation. True change really requires changes in policy, right, that influences social determinants of health. It also includes sustained investment in culturally responsive and community-led approaches, really in combination with already existing evidence-based treatment approaches, right? So it's really listening to the voices of the men who use drugs and not pushing their voices to the side.
Thank you. So, we all that are here have seen the power of doing research in this way, but there were also a lot of challenges. What should people keep in mind who hope to carry out similar community engaged research projects? What have we learned? This is for both of you.
Sure. I would say to any researchers or um, scholars in the audience that get ready to be uncomfortable. The values that underlie research and that we elevate in research and the values that underlie direct service work, especially in communities that have been marginalized and oppressed, are very different. And so there's going to be some incongruence between the values of those two people when they come together to work towards a common goal. And that leads to discomfort. But if you lean into that discomfort and you stick with it and you approach it with humility, you can learn a lot and you can do really meaningful, impactful work that frankly most people are not doing because they don't deal with that discomfort.
Yeah, and I think to piggyback off of that, right, is you lean into that discomfort and you grow these relationships with the community, you learn that in this work, it really extends far beyond, right, data collection and dissemination. So if there's really one thing I would say to take from this is that community engaged research, specifically CBPR, right, the community-based participatory research, it requires that genuine commitment to sustainability and community empowerment, right? This includes things like advocacy and power building and direct action. Most importantly, it just means continuing to show up to support the communities that you're working with well beyond the scope of the research.
Thank you both for grounding us in our findings and the lived experiences behind them. We will have time at the end for questions for all of our speakers. I know we have a lot more to share, so we're going to shift now from what we learned to what we recommend we do about it. So in this next section, Sandra will highlight key takeaways from the research and share recommendations that emerge directly from these findings with a focus on how they can inform practice policy and community-led action.
Thank you, Maria. Hi, everyone. So before diving into recommendation, let's take a look at key takeaways from the previous speakers. Drug use is deeply connected to societal problems, not just individual behavior. The current system is not designed for Black men and often pushes them away and out. Criminalization, poverty, and racial trauma create a feedback loop that fuels drug use. Black men who use drugs are actively practicing care, resilience, and harm reduction. Healing starts with connection, especially through peers, community, and culturally grounded support. To create real change, policies must center dignity, encourage flexibility, and include those affected by drug use and overdose. So given these takeaways, I will be sharing with you cross-sector recommendations for providers, policymakers, and everyone involved that will help all of us in building a stronger and more effective services for Black men who use drugs. So how providers can build better services? They can start by building trust through representation and respect. This is the foundation. Hire Black men into key roles, and not only as peers, but leadership, program designs, and evaluation. Their lived experiences build direct credibility. Move beyond one-time training. Organizations and providers need to commit to ongoing organization-wide learning in anti-stigma and trauma-informed care practices. Model respect in every interaction, from the security guard to the front desk to clinical sessions. Leadership must consistently demonstrate this cultural shift. Providers can also center care around the whole person, address basic needs first. You cannot effectively treat substance use if someone is unhoused and/or hungry. Provide housing, food, and transportation as core treatment and not as extras or add-ons to your services. Create individualized plans with clients. So ask your client, what does one wellness look like for you? And build a plan together from there. Avoid one-size-fits-all approaches. Involve clients as experts. They're the expert in what treatment should look like. Include them in program design. Host feedback sessions and advisory boards. They know best what works for them in your service model and really what doesn't work. Grow community leadership. Train harm reduction champions to lead, teach, and respond. Build mentorship programs led by and for Black men with lived experiences. Launch peer-led support groups and recovery circles. Fund and partner with community-led alternatives to policing in crisis. Providers can make service easy to access by simplifying medication access. Offer buprenorphine with same-day prescriptions and eliminate hurdles and barriers like daily check-ins. Provide mobile outreach services, reach people where they truly are. Collaborate with other providers on drop-in wellness hubs that bring holistic care together in one place. Strengthen harm reduction as a core clinical service. So distribute naloxone test strips and safe use supplies in trusted places. For example, partner with barbershops and churches. Provide harm reduction education to build safety and self-efficacy. Host educational and legal right workshop. This way you can educate communities about the Good Samaritan laws. When people know their rights, they're more likely to call for help during an overdose without any fear. So what policymakers and funders can do, they can back culture-rooted community-led solutions, fund Black-led organizations with flexible and responsive resources so they are able to immediately respond to community needs as they arise. Create dedicated funding streams for culturally specific and culturally appropriate programs. Expand peer-led healing-focused services, especially for Black men. Close gaps in outcomes. Disaggregate your data. Analyze outcome by race and gender and neighborhood. Aggregate data hides who is being left behind. Fund equity audits and community-driven evaluations. They can also measure impacts, not just outputs. Tie funding to meaningful and immediate outcomes, like reducing overdose deaths in hardest hit neighborhoods and increasing stable housing and employment in recovery. Funders need to elevate culturally relevant public health messaging by funding campaigns that humanize and uplift Black men who use drugs. Amplify trusted community voices, partner with and resource barbershops and pastors, elders, and teachers who are the existing pillars of trust in the community already. Link messaging to resource and real opportunities for care. Fund care, not punishment. So invest in jobs, housing, and healing in impacted communities. Shift funds from surveillance and enforcement to wrap around supports and services. And exclusionary policies for people with criminal records related to drug use, and support reentry from incarceration with housing, jobs, and care. True wrapped around services. Funders and stakeholders need to scale harm reduction by boosting access to test strips, naloxone, and other life-saving tools. Advocate to legalize syringe services programs and xylazine test strips in Missouri. Fund Black-led organizations to lead distribution and overdose prevention in their own communities, in their own neighborhoods. is strengthening Good Samaritan protections for those who help in an overdose, and reimburse peer support specialists through Medicaid and Medicare. So what can all of us do? We can start by carrying naloxone, by learning how to recognize an overdose and use naloxone properly. Can keep it in your car, your medicine cabinet, just like you would an EpiPen. You never know when you will need it. Check your assumptions. People who use drugs are part of our communities. They are fathers, sons, coworkers, veterans, neighbors, friends, and our children. There is no single story or stereotype that defines them. The drug use is just one part of their story. Very important, even for people who are doing the work, to use respectful language, most importantly for people who are doing the work. Words matter. Say person who uses drugs or a person with substance use disorder, not an addict or a junkie. Drug use is a health issue, not a moral failure. Fight stigma actively. Stigma kills. Speak up when you hear harmful stereotypes or jokes. Support policies and programs that treat people with dignity, not with judgment. Slide. So here I will be reading a quote from the Center Initiative that will really hone in on the importance of having people who look like the people we're serving, who understand culturally relate to people that we're serving. Most of these people want to see somebody like themselves teaching. That's kind of hard to listen and get that from another person that ain't never been on drugs. Don't stay in the type of neighborhood you stay in and been through any of those things. The only thing they could say is that they looked through a book, seen it on TV, maybe seen a few people that was on drugs, talked to 2 or 3 of them, and they feel like they can help. Most people not going to gravitate to that. So how did the St. Louis Black Harm Reduction Coalition came to be? So it was originally launched as a direct priority for the Center Initiative, though the initiative has now ended. It did provide essential structure and collaborative space to get the coalition started. Through a process led by experts, specifically Black individuals with firsthand experience, the center group defined a clear purpose. They developed the coalition mission, which is to educate and unite the St. Louis community around harm reduction to eliminate substance use-related deaths amongst Black people and the structural harms of racism for Black people who use drugs. And from that mission flows the vision, a St. Louis community where Black people who use drugs are empowered, healthy, and treated with dignity. Please use the QR code to sign in for our monthly coalitions. We'll start meeting via Zoom every month. We'll love to see you and get your feedback on collaboration. And please don't forget to follow us on our Instagram account. Thank you.
Thank you, Sandra. Okay, so we have some time now to hop into a few more panel questions, this time for Sandra and Keith. So, we just shared a lot of recommendations and a lot of different strategies. And I think over the last few years, we have made progress in some of them, and some of them have been a lot harder to move the needle on. So I'm curious from both of you, working closer to the front line, what do you see as the biggest or most urgent gaps between what Black men need and what the current system is offering them?
So the urgent gap, I've seen that the time it takes from somebody say and verbalize and say that I am ready to seek treatment to the time that they are actually getting into treatment is usually weeks, month. And during that time, almost always we lose people. So we lose contact with them, and sometimes people die. there need to be a sense of urgency from when we get buy-in, especially from Black men who we know struggle with stigma, and even for them to be able to have the courage to realize that they have a disease that they need to treat. It's very vital for us to create a pathway where Black men are able to go the same day or next day for treatment. Even 24 hours matter in decision making. So how can we have readily available services when people are ready?
Keith, most
I mean,
urgent gaps.
I mean, I agree. A lot of what Sandra just said, but like urgency, like man, I can't stress this enough. Um, as far as like treatment providers, right? They lack the cultural competency that it takes to understand not just the Black community, but Black men in general. Um, they don't listen, right? They um, they take their own understanding. So, say for instance, I run across a guy, he's unhoused. He may want to get into treatment that day, regardless if he's trying to get into treatment that day just to get out the streets, it shouldn't matter. The fact that he wants to help is all what matters. But you have certain individuals, like I explain to people, the receptionist is the first line of fight. Like they are the person that calls on the phone, the people that connect you. And most 9 times out of 10, those women or men who sit at the desk doesn't understand, doesn't look like me, like the cultural competence that it takes to them is just a job. It's more of like okay, let's get you in 5 days from now, a week, 2 weeks from now. And then once they actually go through the process, they ask them questions that doesn't even make sense. So I just think more training, uh, to have people understand that like it doesn't matter if I'm seeking treatment just to get out of the weather or because of the seasons. It's not on me to prejudge and say when or how. You can't measure a person's desire to want. And I know that personally, for me being a recovering addict myself. So with me and Sandra, like being, as you want to call it, the boots on the ground. That right there, in lies the problem, right there for me.
Thank you. So I know you guys are both very centrally involved with the new emerging St. Louis Black Harm Reduction Coalition. Can you share a little bit, like, what is some of the work you guys are doing or planning to try to address some of what you guys are talking about? This is mostly for Sandra, but then Keith, if you want to also jump in.
Sure. So we have identified 3 areas that we are currently working on elevating and strengthening. So one, we are working with grassroots organizations that are Black-led, Black-serving, that have some capacity of harm reduction work to help them with elevating their harm reduction practices. And we are also providing them with trauma-informed care workshops to their staff. And we also offer it to their community members, to the staff, to be able to allow them and educate them on some practices that they may be doing unknowingly that has negative impact on their service delivery. We are also working on funding to grassroots organizations or individuals who have innovative harm reduction ideas and would like to work in the St. Louis region to elevate harm reduction and also to create new harm reduction ways that Black people could benefit from. So we are working on creating our online platform to be able to provide the trauma-informed care trainings to organizations and to policy makers and funders, and just work closely together. We are also helping organizations that are boots on the ground to collaborate with other organizations who are boots on the ground, recognizing that the job is hard, recognizing that they don't have time or capacity. That's where the coalition is coming in, trying to bring people together so their offerings could be strengthened and actually even help them as individuals with their work whenever we have time and capacity.
Keith, anything to add? I don't know.
No, I mean, she basically covered it all.
Great.
I just bring my experience from being a part of the center initiative into being the CAB manager of the Black Harm Reduction Coalition.
Yeah. No small
I
thing.
mean, it's and me being a Black man as well. So, but Sandra does a great job as far as leading the charge. So I just ditto everything she just said.
My next question, it's a little rambling maybe, but I want to situate us in 2026. So, the center initiative kicked off in the midst of COVID, and it was a very different time. This research study was done in 2023. It's an interesting time now because we have been seeing overdose rates among Black men going down. And I think there's likely a lot of reasons for that, some of which is hopefully the work that we've been doing together, getting more naloxone out of the community strategically, creating more relationships to be able to get people the services and things they need. So we're seeing sort of this like positive trend, but then also this broader landscape in a lot of ways has been sort of taking away resources from some of this work or less supportive of some of these strategies. So kind of with all that in mind, like this work is hard. What kinds of supports do people, the boots on the ground, kind of need to keep pushing and making change? How can we support you? What should we know?
So for the boots on the ground, I would say start with thank you. I see you. I see everything that you're doing and I appreciate it. Working on outreach every day, working, when it's hot, when it's cold, different weather, it takes a toll. And unfortunately, sometimes you see people for many years with it's still, the same. They come, they get supplies, they get Narcan, and they leave, and the cycle continue. So I think us as a community, recognizing that boots on the ground actually have it the hardest, also offering support and ask them what support should look like. Just it's a phone call or just go to the organization and be like, how would you like me to support you? And they are the experts of what they need. They are the experts because they are 5 days a week, sometimes 7 days a week outside of what people need. So I always say, ask them. Definitely fund Black-led, Black-serving organizations. And couple that with technical assistance and a lot of admin support. Lots of grassroots organizations don't have enough funds to have that. They have most of their staff, if not all, are boots on the ground. So how can you be able to fill that gap with funding? And also funding will allow grassroots organizations to hire more people with livable wages. I will say create, focus groups, or you can, your organization can support during inreach or outreach with resources, and make it not a one-time thing, make it a regular thing. Put it in your budget that you're supporting other organizations. So I will say funding, and your time, and just your appreciation to what they're doing, because it's not easy.
Yeah. I mean, just to put it like very, very simply, money. Like Sandra said it great. Like with all these great things, I mean, we can talk about a lot of great things and uh all these different programs, but without money, none of this happens, right? And she put it in a way to where it was nice, funding. Yeah, money. That's what we need, money. It takes money to make things happen. Because like we don't get a decompression process. It's nonstop. When you boots on the ground and you're taking on different energies, you might go over here to the unhoused part or an encampment, or you might go over here. You're offering, because I'm a CHW as well. So you're doing trauma informed care here, and it's just like a non-stop thing of just energy. And sometimes the energy is not so great. And so when you take that energy, because 9 to 5, as they said, but as anyone that does this work knows that like there's no such thing as 9 to 5. Uh, you take this work home with you, even though you don't supposed to, because it's hard, when you have a community member that you didn't dealt with for the past 3, 4 months, only to come back to a certain area and he or she is not there anymore. They either passed away from overdose or violence, you know, because it's just much more than like overdoses in the streets. Other unhoused people commit violence on one another as well, either for their property or drug dealers come through and they use them as guinea pigs, you know, to try out their new supply. Like like these are the harsh realities of being an outreach worker that you see, or you may pull up and see a drug dealer out there selling them drugs. And what can you do? Like, because for your safety, you have to remain safe. And also, you must understand that they have a choice as well. So, and not only just funding, man, we need more of the city backing. We need more of the state funding backing policies and understand, man, that the unhoused needs protecting as well, man. I hate to use the word homeless, uh, but like they need, instead of this, just being disregarded as just, oh, that's a choice. Like everyone that's unhoused is not drug users. Like they don't. Everybody's story is not the same. You know what I'm saying? But if you don't actually get out there and actually get a feel for it, but just to put it bluntly, without me rambling, money.
I don't think you were rambling. That was a lot of great insight. Thank you. My final question for both of you is, I think, similar to the question I asked Devin and Kay. We covered a lot in the report, the themes, the recommendations. As people, leave today and go back to their job and all the other things in their life, what is something that you would want them to walk away with or remember from this or be top of mind for them out of all of the stuff that we've covered?
So, I'll say if I still use the same cross sector that I used earlier, so for policymakers and funders, I'll say immediate thing, just learn more about grassroots organization, visit grassroots organization in your area and talk to them, talk to people who do the work. That will be able to give you an idea. It's one thing you see it on paper as data, is another thing when you actually talk to a person who's doing this job and who has passion. It's different. For providers, I'll say immediate change. I mean, a lot of participants that when I worked at the Power for STL or the T is One thing we did is we didn't have appointments for clinics. People can come. We had days and hours, so people had like a 6 to 7 hours windows where they can come at any time. There's no 15 minutes. We understand you're unhoused. You probably walked for miles and miles. It was harmful when we had the late or the 15 minutes or the 30 minutes that they're late, we cancel. You could see it in people's faces. You could see it in people's bodies, how harmful that is. And you could see how the positive change that happened when we opened more. So open your appointment slots more, understand, ask your patients, what days do you prefer? What times do you prefer? Allow patients to have a say. And we seen that people who preferred Wednesdays compared to Mondays were coming every Wednesday at the same time. They were able to formulate their own appointment time organically. For community, I'll say if churches or your place of worship, uh, something as simple as overdose education and naloxone distribution class during your Bible study, or whatever you go and you gather with your loved ones and your community, talk to people about language. Language matters, and the stigma, especially for us Black community, stigma still exists. So having conversations and just allowing people to have safe spaces where they can speak based on their experiences, but also where they can learn. Because even the people we serve, when we teach them how to use naloxone properly, they're teaching their family, their chosen family in that VACO building, how to use Narcan properly, how not to use alone. And this is how we're able to change systems by investing in the community and teaching. It's people who use drugs are still able to learn. They're still able to feel. So how we present information to them matters. How intentionality and the thought we put in delivering messaging matters. So just all of us, we can do this, not one entity.
And I would just simply say to providers and policymakers and all, like just all of them, just as a totality, like I'm trying to put this out in so many bodies. Get in the game. Like if you want to see where your money's going, if you want to see how things really work, come from behind your desk, schedule an outreach to come out with, reach out to Sandra, Maria, meet like, and come and see like really how the people really live, how they get disregarded. Because it's easy to talk from the sideline. Like it's real easy to prejudge from the sideline. But if you really, really want to know what's really, really going on in your city or your state, get in the game. Like it's real simple. Like it's not hard. I was talking to this older guy last week, and he was like, "Yeah, I remember. I used to do outreach, and I started off outreach, and I was like, yeah, but you got to update your resume, pops. Like it didn't change. Like from '95 to 2000, and I didn't mean that in a harmful way. I was just keeping it real with him because he was talking. He was talking from a place of privilege, right? Like he was talking from a place of, yeah, I done outreach, so I ain't got to. I understand how. No, you don't. Like you really don't. Like because I had to, like there's a difference between outreach and street outreach. What me and Sandra gonna do is street outreach, meaning we go to the depths of hell, like where people like really really need the help at, like where certain individuals don't go. But uh, just to sum it up, man, just get in the game. Like, put your sneakers on and your jeans, and that way you can get a better feel for what we're talking about and what's really, really happening out here in our city. Like where your tax money is actually going. So that would be for me to anyone who's watching this webinar, come from behind your pretty desk, schedule a date if it's once a month to where you want to come, a ride along as they call it. You can reach out to me or Sandra or anyone on this panel, which can connect you to someone that does street outreach. That way you can get a feel, because it's not like seeing it for yourself and understanding why research like this matters. And when it comes to serving the people, because at the end of the day, it's always about the community. Like when people get through talking, it's always about the people.
Thank you, Keith. And thank you to all of our speakers for sharing their time and insight and honesty today. I think your different perspectives kind of underscore the complexity of the issue and the impact of coming at it with different approaches and superpowers. We need all of it. So we now have some time built in for questions, which could be for a specific speaker or for all of the speakers as a group. I believe the Zoom has a chat. We had a few come in with registration, so I'll kick us off with one, and then if anyone has any questions, you have a minute or two to submit it in the Zoom. So my first question that we had was, are there any indicators that we can identify ahead of time for the purpose of prevention? So we haven't spoken a ton about prevention today. What should people know, or are there things people should look for?
Well, I'll say prevention is a spectrum. So, I think, are we talking about prevention of substance use disorder in general? Or are we talking about, who might be at a risk for first overdose? And I think maybe Sandra could speak to that latter one. But in terms of primary prevention, and how to identify quote unquote risk, drug use is fairly normal. Drug use is fairly normal. It's normal for young people to be curious. It's normal for young people to try things. But what we heard in these stories is that when they had a lot of access to powerful drugs in their home, in their social networks, that is where they got into a situation that extended beyond what they expected. And so I think when we're thinking about prevention for young people in general, it's looking at their environment. It's what supports can you give? Is there drug use happening in the home? Is there drug use happening among older cousins or friends or the people watching them? What's their access like? Do they have easy access? And then what supports can we provide around the family unit to mitigate some of that potential harm? Sandra, do you want to say anything about kind of risk for overdose prevention?
Sure. I agree and echo Devin. And I also want to add that it's important to normalize talking about drug use and provide safe space in all your environments, home, work, schools, because even within your home, even if you are not using drugs, your children they still go to schools, they still around so many different people. They get information usually from friends or online, and it's not true. So how you can have a safe space at home where your child can come and ask you questions and you're able to provide them with answers. Involve children in workshops, in educational classes that are age appropriate. And also drugs are more prevalent than we think. When I talk to people, they say they can just get it from high school, like $5, they can get a pill. Unfortunately, when I had access to overdose data, I mean, there was, it doesn't discriminate all age groups. So even our elders, accidental overdose do happen. So how can we educate people and provide tools? Teach your children, teach your elders how to use naloxone. Let them, be familiar with it and not scared of using it. Naloxone is safe. They can use it on you, and you can show them firsthand that it's safe and nothing happens. So I would say just normalize talking about substance use as a disease instead of it's still associated with stigma and behavior and choice.
Right. And just to add to that, right? I mean, and I agree with Dr. Devin and Sandra. Like the problem is not the drug use. It's when it goes from drug use to abuse. Like that's when it starts to become a problem, right? And the first teacher starts at home. Like you don't send your kids to school to learn about life. You send them to school to learn about education. But the first teacher starts at home. So 9 times out of 10, children copy what they see at home. So if you have a disruptive home, or if you're abusing drugs or alcohol at home, that right there, that starts trauma from the inside. Like you always want to retrace where the problem came from in order for you to fix the problem. So if they're seeing mother, father arguing all the time, you can have a beautiful house, you have a beautiful home, mom, dad, work, all that. But if there's any type of dysfunction within that home and you're not talking to your child about this, because they'll start off with just taking mom or dad pills out of the medicine cabinet. Like it'll start off small. But as a parent, I've learned through experience that you have to be careful and you got to watch those signs that your kids are giving off, right? And once you start to see signs, you address those signs. I mean, even the smallest, the little thing, but the first teacher starts at home. So, and I talk to my kids about a little bit of everything. So yeah, I think in my personal experience, man, the very first teacher starts at home, as I said once before, and you got to watch the telltale signs when it comes to children and their behavior.
Thank you, everyone. Um, Kind of a topic switch, but if I wanted to form a community advisory board or engage in community-based participatory research, what would you recommend doing or accomplishing in that first meeting to establish trust and start the collaborative process on the right foot?
Okay, so two things. One, sometimes community people approach community engagement like it's the wild, wild west. Like, oh, okay, cool, I'll just have a meeting or whatever. There are evidence-based tools to engagement. Like there are tools out there, and you should not be creating tools, especially and you should not just be flying by the seat of your pants, especially if you've never done this before. Go to people who've done it before, go to toolkits. They're out there, they're freely available. Use evidence-based tools. And what most of those tools will tell you is that at the top of your engagement, you need to make very clear what the project is and what the roles of the community members you're asking to be involved are. And so orientation, 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 because that helps people have the agency to figure out whether or not they'd like to be involved, as well as it helps them start thinking about how they can contribute based on their skills and interests. But where you really get into trouble is when you say, this is, when they say, okay, here I am. And it's like, what are we doing? What is the purpose of these meetings? What am I supposed to be adding here? And there's a lot of why me? And a lot of role confusion. And that includes being honest about what you don't know about the project yet and where you think their roles might evolve.
I'm curious if Keith has anything to add here as a community advisory board member, but Keith went off camera, so I'm not sure. Keith, are you still there?
No, he
Oh,
stepped away for
okay,
a
gotta go to
second.
the restroom.
So I will add to that, Maria, if we have time. So for us at the coalition, it was very important to have an introductory meeting with our CAP or with community members um, who are interested to becoming that CAP members. We laid down clear expectations, what they need to expect from us as an organization and what we're expecting from them as members and how this relationship can get disconnected at any point if both parties or any of the parties are not holding their part of their part. We expect people to show up. We know life happens. If they're not able to show up, let us know. So we had really, I wouldn't say rigid, but we had really clear expectation that we shared with people with the caveat that we know life happens. So please let us know how we can support you. Also, the goal for us at the coalition is to invest in our CAB members. They are providing us with great information and lived experience and living experience. So how can we provide you with something whereby, let's say you are no longer a CAB member, you can take the knowledge and the education you gained to move forward in life. I would say also compensating them, and we were very adamant about be able to provide livable compensation based on their experience and how many of experience they had. And that's something we were honest about to our funders. So yeah, so I would say look at it as a bidirectional relationship. You are gaining knowledge. What are you providing to CAB members?
Hmm? And that's not just compensation. The question didn't say
Knowledge.
this specifically, but this, it's specifically when you're working with people who have been who are marginalized or oppressed, that in that first meeting, you need to assess what type of support they need to be able to get in order to engage. Is that transportation support? Is that making sure they're fed? Is that what kind of trainings are they going to need in order to be able to engage? That empowerment and capacity build it, not just expecting people to be able to engage day one, and recognizing the gap, like Keith said earlier, that they've been excluded from research from this process. And so you're going to need to start figuring out what supports they need to actually engage.
Yeah, and I think just to kind of piggyback off of everything that's been said so far, I definitely feel like, right, that first meeting alone isn't going to establish trust, right? It takes time. It really takes a lot of time. And so just being open, right, to being uncomfortable and being ready to step into a space that you're gonna have to learn as you go sometimes, right? Like Devin said, there are lots of toolkits and things that are out there to really help guide you in a very like evidence-based practiced way, but you still want to be mindful that you're still learning along the way, right? And so everyone is learning in their own way. And so taking that time to establish trust is going to be really important.
I think if I have one reflection from all of this work, it's that it takes time. And so uh we even this is 5 years in and we're still learning, we're still building trust, we're still growing. And so yeah, I think anytime you start looking for easy answers or easy solutions or easy, that is, I think I've noticed when you can get into trouble. Um, so I'm recognizing the time. As we come to a close, I want to thank everyone who joined us today. I want to extend gratitude again to our speakers, the partners who engaged with this project over many, many years in many, many different ways, our funder, the Missouri Foundation for Health. And we hope you leave today not only with new insights, but a renewed sense of shared responsibility and possibility. Thank you for being part of our collective effort. Please reach out to us. This is just 1 hour, but we really want to be in partnership and community with people that are looking to make a difference in this area. So I believe that we have a post-webinar eval. I'm not quite sure exactly. The survey will pop up for you when you close. So please fill that out if you're able, just so we can gather some more information from you and what you learned and what you're seeing on the ground as we continue to carry out this work. So thank you, everyone, and have a great rest of your day.